Greetings from ECS Heart. I'm Dr. Bassam Atallah, Pharmacotherapy Specialist in Cardiology at Cleveland Clinic, Abu Dhabi. I'll take a few minutes to discuss the evidence-based medications for heart failure. As you know, in heart failure, we have two main categories, including heart failure with reduced ejection fraction and heart failure with preserved ejection fraction. I will go ahead and start discussing heart failure with preserved ejection fraction. As you know, we don't have many evidence-based medications for HFpEF. However, recent data have suggested the use of mineralocorticoid receptor antagonists, including spironolactone, for some evidence in studies, including the TopCat study, where spironolactone was found to reduce hospitalizations. This recommendation is now part of the guidelines, despite being a weak recommendation given the results of the TopCat that were a little bit controversial based on the geographical differences in the patient population. However, it's important to remember that whenever you are initiating a mineralocorticoid receptor antagonist such as spironolactone or eplerenone for your patients, to monitor potassium closely. In fact, it would be important to monitor potassium at baseline, then within 2 to 3 days of initiation, and then at 7 days. Because with spironolactone or MRA class in general, the hyperkalemia can be quick, and it's important to monitor that initial initiation phase for MRAs. If we switch gears and we move on to HFrEF, or heart failure with reserved ejection fraction. Of course, in this category, we have a lot more evidence-based medications. We know that the beta blockers, the one that with proven mortality benefit, include bisoprolol, carvedilol, and metoprolol succinate. As for the ACE, ACE inhibitors is a class effect, meaning that you can utilize any of the ACE inhibitors for their mortality benefit. The other medications in that class of RAS inhibition, which, as you know, is important in heart failure, given the increase in the RAS response when the patient is in heart failure, is ARB and ARNI. ARB is not angiotensin receptor blocker, is not a class effect, unlike the ACE inhibitors. You can only use certain medications that have proven mortality benefit, including valsartan, candesartan, and losartan. If we move on to the newer class of medication, which was approved in the last few years, that's the ARNI, angiotensin receptor neprilysin inhibitor, namely sacubitril valsartan. Also, there is a criteria to choose patients that are appropriate for this medication. While with the initial approval of the medication, it was only for patients who are already on ACE or ARB. Now, with more recent study, we can consider initiating this medication de novo, meaning that for patients who are not yet on RAS inhibition. This medication is available in in 3 doses, the 50 milligram, which is also always given BID, 100 or 200 milligram BID. As previously stated, the last class of evidence-based medication for HFrEF is the MRA, which also have some benefit now for HFpEF, and these two medications include spironolactone and eplerenone. And thank you for your attention.